Good morning, everyone. In this talk, I am presenting our findings on the spectrum of bone marrow and peripheral blood pathology in patients with ADA2 deficiency who were seen at NIH. So we reviewed bone marrow biopsies, aspirate smears, flow cytometry data, peripheral blood smear, clinical, laboratory, and demographic data and molecular results from 9 patients with confirmed germline CECR1 mutations in NIH. Age at presentation varied from 5 months to 19 years of age with a median age of 3 years. 4 of the patients were male and 5 were female. Of the 9 patients, 8 had a compound heterozygous mutation in CECR1 gene. The most common clinical presentation among these patients, the ones with compound heterozygous mutation, was vasculitis and or strokes. The second most common presentation was recurrent respiratory infections, predominantly of the upper aerodigestive tract. There was one patient with a homozygous mutation, 794C2G, resulting in a stop codon, presented with severe immunodeficiency features involving recurrent respiratory infections, including Mycobacterium avium intracellulare infection and multiple cytopenias. This patient was initially clinically diagnosed as Monomax syndrome or GATA2 deficiency, but a GATA2 mutation was never found. Then following bone marrow transplantation, later a whole exome sequencing was performed, which detected CECR1 mutation. Notably, this patient did not have vasculitis or strokes. A total of 12 mutations were identified among the 9 patients, all compound heterozygous for 2 different mutations, except for the one with the homozygous mutation. 8 of the 8 tested patients showed hypogammaglobulinemia, predominantly affecting IgM and IgA levels. 4 of the patients had IgG, low levels of IgG. The peripheral blood showed microcytic anemia in 5 of the 9 patients. 5 out of 8 tested had low serum iron levels as well. There was neutropenia in 2 of the 9 patients, one of which had complete agranulocytosis, that is absolute neutrophil count of 0, the one patient with the homozygous mutation. The absolute lymphocyte count was reduced in 7 out of 9 patients. These 7 patients out of 9 also had NK lymphocytopenia. 3 of the patients showed severe B lymphocytopenia, and 5 of them showed a reversed CD4-CD8 ratio. None of the patients showed an absolute increase in large granular lymphocytes. 6 patients had peripheral smear evaluated, and 4 of them had large platelets in the peripheral smear. And 5 showed microcytic hypochromic red cells with moderate anisopoikilocytosis. Only 1 patient had a borderline thrombocytopenia, the one with the homozygous mutation again. Flow cytometry was done on bone marrow aspirate in 4 of the patients. When we perform flow cytometry in normal controls for analysis of CD19 positive B cells, we see a very characteristic reproducible B cell maturation pattern as shown on the left side, with CD10 bright immature precursor B cells, and then they gradually acquire CD20 positive. You can see that cells going towards the right, towards CD20 positivity to become intermediate B cells, and then they lose CD10 positivity and acquire more, like bright CD20 positivity to become mature B cells. 3 of the 4 DADA2 patients who were analyzed had a strikingly abnormal B cell maturation pattern with detectable CD10 positive precursor B cells and markedly decreased or near absent CD20 positive mature B cells, suggestive of maturation arrest or loss of mature forms of B cells by another mechanism. Per history, none of these patients received rituximab treatment prior to bone marrow evaluation. 6 patients had bone marrow biopsies performed, and 5 of them had hypocellular marrow for age. For example, the left side figure is from a 16-year-old female, and the right one from a 19-year-old female. There was mild megakaryocytic atypia in all the 6 marrows, including hypolobate forms and focal cluster formation of megakaryocytes. The left one is a Necheney stain, you can see a cluster of megakaryocyte. The right one is a CD61 stain, again shows the range in morphology of megakaryocyte. There is the left top of the CD60 stain, you can see a small cell that's a micromegakaryocyte, and here there is a megakaryocyte with separate nuclear lobes. 4 of the 6 marrows showed increase in interstitial T cell infiltrates with T cell aggregates. The CD3 stain on the left side shows the interstitial T cell infiltrate and the center with the aggregate, and this was accompanied by a near absence of CD20 positive B cells in the marrow. You can see the right side image. Bone marrow aspirate smears showed variable atypical morphologic features in erythroid and myeloid precursors as well. Dyserythropoietic features included binucleate forms and occasional nuclear budding in a subset of erythroid precursors. And on the right side, I have shown that the erythroid and myeloid precursors showed fine or coarse vacuolations in the cytoplasm. The one patient with the homozygous mutation had severe myeloid hypoplasia, agranulocytosis, and marked left shift in the present myeloid precursors. So these pictures are, the left side is a bone marrow biopsy and the right side is a marrow aspirate. You can see there are numerous erythroid precursors and some granulocyte precursors, but no segmented neutrophils. In conclusion, patients with CECR1 mutation in our cohort presented with vascular and immunological manifestations with variable cytopenias. There was significant B lymphocytopenia with an atypical B cell maturation pattern in the marrow and NK lymphocytopenia. The bone marrows were hypocellular for age in 5 out of 6 patients. There were mildly atypical morphologic features in megakaryocytes, mild dyserythropoiesis, and cytoplasmic vacuolations in erythroid and myeloid precursors. Bone marrow biopsies showed a prominent increase in interstitial T cell infiltrates and T cell aggregates. Whereas these findings were similar in 8 patients with compound heterozygous mutations, the one with the homozygous mutation presented with severe immunodeficiency and marked cytopenias. There are other groups who reported cases of pure red cell aplasia as presenting feature of DARA2, but notably none of our patients had pure red cell aplasia. Also, absolute increases in LGLs have been described as a presenting feature in DARA2, but none of our patients had absolute increase in large granular lymphocytes. This work was done with Dr. Catherine Calvo in collaboration with our colleagues at National Human Genome Research Institute, National Institute of Allergy and Infectious Diseases, National Cancer Institute, and National Institute of Health Clinical Center. With that, I conclude my talk. Thank you very much for all your attention, and we'll be happy to take any questions later.